Good morning, good afternoon, and good evening to all our colleagues from all around the world, and thank you for being with us in special days. First of all, Happy Mother's Day to all our beautiful mothers, and as well as Ramadan Mubarak to our Muslim community. So it is my delight as the president of the IPOSC and the now almost 7 years of editor-in-chief position of the American Academy of Ophthalmology One Network, Knights Templar Eye Foundation, Pediatric Ophthalmology Education Center. This session, as you know, is hosted by the Pediatric Ophthalmology Education Center team members. I would like to thank them, first of all. And it is in collaboration of our very active Egyptian Association of Pediatric Ophthalmology and Strabismus and IPOSC. From now on, you will see that we will have monthly IPOSC local meetings, and the next one is going to be in June with the Lebanese Society, then in July with Taiwanese Society, then in August we will have the Russian Society, September Indian, October Chinese, November Brazil, and December Australia, New Zealand, and January Turkey, and so on and so forth. So please join us. I would like to also thank Dr. Jason Yam as well as Dr. Sonal Parzavanti for their amazing work to put this whole series together. What a pleasure to have been kickstarting this session with our fantastic, one of the most busy committees. So with that, I would like to hand it over to Dr. De Faber.
Hello, dear friends. I would like, together with Dr. Adel Eldain, to give the introduction to the combined IPOSC and EAPOS meeting. And don't worry about the barking dog. It's part of the presentation. And this meeting will be a Strabismus reoperating meeting. This is myself. I'm a pediatric ophthalmologist in Rotterdam, the Netherlands, and also the ophthalmic consultant of the Rotterdam Zoo. Next slide, please. And the incoming president of IPOSC in about 1.5 years. The other moderator is Adel Eldain. He is a pediatric ophthalmologist and professor in Gizeh, and he is the mentor of the Pediatric Ocular Oncology Cancer Center in Cairo, Egypt. And we are the moderators, and we will do this alternating. First of all, we would like to introduce the speakers. And the first speaker is Ayman El-Ghunaimi. He is a pediatric ophthalmologist consultant in Egypt, at the El Maghrabi Eye Hospital, but he's also the treasurer, money counts, of the EAPOS, and he will speak about management of consecutive esotropia, a stepwise approach. Then the next speaker will be my dear friend Rosario Gomez de Liano from Spain. She is a professor in Madrid, also the president of the International Strabismological Association, the ISA, ex-president of the ESA, and ex-president of the Spanish Pediatric Ophthalmology Association, and also the ex-secretary treasurer of the IPOSC. She will speak about tips for the management of consecutive exotropia. She will be the second speaker. Then we go to Dr. Lobna Kashbak from Egypt. she's a pediatric ophthalmologist and emeritus professor at Cairo University, and head now of the pediatric ophthalmology and strabismus unit at the Al Noor Eye Hospital in Egypt. She actually will give us 2 talks. One, the management of residual horizontal deviation. The first talk will be on esotropia, consecutive esotropia, and the second talk will be consecutive exotropia. So she will cover the whole horizon. Then Miho Sato, she's a professor of ophthalmology in Japan, vice president of the Asian Pacific Pediatric Ophthalmology Society, and president of the Japanese Association for Strabismus and Amblyopia. And Miho, she will talk about reoperations of superior oblique palsy. And then we go to Dr. Ahmed Abadin from Egypt, professor of ophthalmology in Cairo University and Secretary General of the IPOSC. And he will talk about reoperations of paretic strabismus. How early is too early? Or actually, when will you do your surgery on time? And then last but not least, Dr. Saurabh Jain from the United Kingdom. He will give us intraoperative tricks for reoperations. And Saurabh is a pediatric ophthalmologist and consultant in London. And that will give, yes, here is his introductory slide, intraoperative tricks for reoperations. These are the 6 speakers we have, and now we will start with the first talk, and that is Dr. Ayman Echnomi. Please, Dr.
Where you are. First, I would like to thank all those who put effort in making this webinar possible. I would like to thank the IPOSC. I would like to thank the American Academy for hosting this webinar. And I would like to thank all my colleagues in the Egyptian Association of Pediatric Ophthalmology. And I would like to thank all the attendees for attending this talk. My talk will be about management of consecutive esotropia, and I would like to make it on a stepwise. Although its incidence is about 6 to 20%, yet the management of residual and consecutive strabismus and the strabismus reoperation is usually poorly studied and poorly discussed in the literature, and there are no agreed nomograms, and it depends in a great extent on the personal experience of the surgeon. How to avoid this happen? The accurate measurement of the angle of deviation is extremely important, and especially checking for the distance and near, and checking the sensory status. And regarding the proper decision, like when to do surgery and which age you operate and what's the surgical dose modification need, especially in younger patients. And the surgical technique is extremely important to avoid slippage of the muscle. The risk of consecutive esotropia is one of its simplest forms, that in intermittent exotropia, the patient having fusion and sometimes is aligned, and so cosmetically sometimes have a good pictures and good selfies. But in consecutive esotropia, there is no fusion, and hence, and the vision is all the time, and hence going for suppression and amblyopia, especially in the amblyogenic age, and in older age, the patient is diplopic. So when we're faced with a patient who has consecutive esotropia, how to manage? There are some rules like counseling the patient, proper orthoptic evaluation, and some conservative measures we have to put in mind. And when we talk about operation, we have to answer some questions. Regarding the counseling, the preoperative counseling is extremely important about the possibility of having a consecutive and the possibility of having a reoperation makes things and the decision easy postoperatively. And of course, the postoperative counseling is important to respect the patient's fear and to reassure the patient. The proper orthoptic sheet is the cornerstone. especially checking the abduction, because limited abduction means slipped lateral rectus. And of course, checking the 9 gazes and measuring the angle in primary position in distance and near, and the prism OD and the prism OS to detect if there is any change or any difference in the primary and secondary angle of deviation. Yet, in the first week post-operatively, it's desirable to have a small consecutive esotropia like this patient who underwent surgery for exotropia. And as we see this, the same patient 2 months after the surgery, the esotropia disappeared. So how to differentiate if this consecutive esotropia is due to slipped muscle or not? Usually in slipped muscle, we have a limited abduction and the esotropia is for distance more than knee because the pathology is in lateral rectus. However, in simple overcorrection, that's not the case. Also, when we measure the angle of esotropia for when the prism on the right and prism on the left, we have some difference because there's a difference in the primary and secondary angle of deviation, and there is a difference in the right and left gaze, as we can see in the picture below. The patient had left limited abduction and esotropia more to left gaze. So simply the slipped muscle is an incompetent strabismus. The conservative measures needed, like the eyeglasses, if we have myopia, we give this minus, especially if the patient had already over minus preoperatively. And of course, with hypermetropia, we increase the plus or even giving full cycloplegic refraction. The patching is an important tool also. I usually do alternate patch 2 hours daily. This can help in diminishing diplopia and actually helps in regaining the proper deviation. Using of the prism can help in avoiding of diplopia. We can give, if a small amount, we can give it ground in, but usually it's when it's a bigger amount, we use Fresnel prism, and we target less power. Just try to avoid the patient eating of the prism and tendency to increase the deviation. Although in many papers that the rate of decline of the prism is about 4.2 prism diopters in annual rate, and the duration to wear glasses is about 2 years. The Botox injection results varies from 52 up to 90%, so it's one of the good options. We can use from 1 to 5 units in the medial rectus. Now the question when to operate. The chance for reoperation in cases of consecutive esotropia is about 30 to 50%, with higher risk, of course, if originally the esotropia immediately after the surgery is quite high. Whether to advance the originally recessed lateral rectus or to recess the medial rectus, there are many factors to put in mind, and a lot of studies have studied this with different results. I'm trying in this algorithm to put some step and guide you on how to manage this patient step by step. When you face a patient with consecutive esotropia after exotropia surgery, the first thing is to check the abduction. If it is limited abduction, so we will have incompetence. And as we mentioned before, the signs of incompetence, like the prism OD different than prism OS, the ipsilateral gaze is more than contralateral gaze and distance more than near. So if we face a case like this, which means that there is a slipped muscle in the lateral rectus. So we have to go and attack the pathology and advance this lateral rectus. But if the patient presented later, a long time after the surgery, we may face a pseudotendon or a stretch scar, so it has to be resected with the recession, with the advancement of the lateral rectus, as I will show you in a video later. But if we have a normal abduction, still we can have some over-weakening of the lateral rectus. So detected by the signs of incompetence I have mentioned above, and then I deal with the patient as a limited abduction. But if we have a normal abduction and still no incompetency, that's a big room actually for conservative treatment, as we mentioned, like playing with the glasses, alternate patch, prism, and so on. So if with conservative measurements the patient improved, that's well, and just follow up the patient. But if there is no improvement after a few weeks and still a significant angle of esotropia, then we have to operate. And again, which kind of surgery you go for? I for myself prefer that if we have a distance more than near, I go for lateral rectus advancement. And if I have it's near more than distance or the same, I do medial rectus recession. So some surgical tips for the operation. The dose, it varies, and again, the personal experience has played a role, but in general, 1 millimeter of lateral rectus advancement corrects about 4 diopters, and 1 millimeter of medial rectus recession corrects about 3 prism diopters. Yet, we have to put in mind that this dose can be modified according to the amount of lateral rectus has been recessed. Like if we have a significant recession, amount of recession of the lateral rectus, so it's over weakened. So I'm weakening a medial rectus with an opposite lateral rectus that's not normal. It is already weakened. So I have to modify my dose. If we face a patient with stretched scar, that's very important, because when I put my suture, I should not put the suture in this stretched scar, because this will cause again slippage of the patient. I have to go back and search for the actual tendon and take my suture in the actual tendon. This nice video shows that how can easily we see the hook behind the tendon, what's called a see-through sign. So this means that this is not an actual tendon, actually. This is a pseudo tendon, and it has to be resected. And I have to go back till I see the original tendon and my sutures there, like we can see in this video. This patient with the resection of the pseudo tendon, as you can see, the first suture is not exactly on the tendon, it is in the pseudo tendon. That's why another suture has been taken backward in the actual tendon, and the pseudo tendon has been resected, and then the sutures taken. This is the patient with the limited abduction, and as you can see in the bottom, that in the bottom of the slide, that the abduction has improved. A last surgery for a patient that we operated like 1 week after the original surgery, which was a lateral rectus recession by hang-back technique, and there was a limited abduction, and we decided to go and advance this lateral rectus. As we can see, it's a fresh muscle. It's you can see there is no actual stretched scar. It's just some tissue on the suture. So we just expose the vicryl suture, and if it has a good strength, we can just advance the lateral rectus and apply a new knot, so for a new insertion for the muscle towards the original insertion. This is a reminder of the algorithm that I believe could be helpful, and I would like to thank all of you for listening and waiting for the discussion.
Yes, thank you, Dr. El-Ghoneimi, for your nice presentation. I really appreciate it, and I would like other participants, if you have a question for the presenter, please type it in the question and answer file. And what I really liked of your presentation is that when I was a fellow with Gunther van Noorden, he always said in this situation, where is the beef? And at that time, that was a commercial of Wendy's, which is a fast food chain in the United States. But what he really meant is, if you are confronted with a pseudotendon, go as far back until you see where the muscle is. Go for the beef. And that's something which really stayed in my mind during my whole career, and you showed this beautifully in your video, for which I would like to thank you. Another question.
I will use this expression. It's very interesting.
Yeah.
For the...
And how long do you wait in terms of weeks after you see a consecutive exotropia or an undercorrection or an overcorrection, actually, and limitation of abduction? How long do you wait?
Well, it's either obviously a significantly slipped muscle. Mm-hmm. Then I usually operate after 1 week when it's obviously a slipped muscle. But if it is a case where it's query, the esotropia is not very big, and the limitation is like -1 or something, I usually wait and use the conservative measures and wait. I prefer when I decided to wait more than a week, I prefer to wait for like 6 weeks or even more, just to have the full picture or the end picture of after resolution of any edema or any other factors, and see and reassess the angle of deviation at that moment if we need to operate or not.
Thank you.
May I add a point? There is a question from the audience about what are the risk factors for slippage. Ayman?
Yes. Okay. Yeah, the main thing that can lead to slippage of the muscle is that the suturing was in the sheath of the muscle, not in the tendon of the muscle during taking the suture. And of course, it's more popular now that we operate on the muscle without moving the sheath. I think most of us are doing this. So putting the sutures in the sheath, not in the tendon itself, can lead to the muscle that slip back inside its own sheath. So that's why we still have some movement. It differs, of course, than lost muscle, like intraoperatively when the muscle being disinserted and lost. That's completely different. The lost muscle, we have a -4, we have zero action in the muscle. But in the slipped muscle, the muscle moved inside its sheath. So that's why it's a little bit weakened and it's a bit easier for the surgery to gain. So the main point is we have to secure the sutures. For myself, I use a central knot all the time. I put a central knot partial thickness in the muscle, then partial full thickness in both sides, hoping to secure the tendon to avoid the slippage.
Yep. There's another question from Silay Ugerbas, and this colleague would like to know whether muscle slippage is more common in people who develop keloids. You know,
well,
scar tissue.
You want me to answer? Yeah.
Mm-hmm. Yes,
yeah, I believe the patient with keloids have more tendency to have the stretch scar more, and those patients usually develop the stretch scar bilaterally.
Mm-hmm. And have you seen in your practice
of the other panels?
Yeah, and have you seen in your practice that after you repair the slip muscle that it recurred?
It may happen. Thank God it's rare to happen.
I haven't seen it.
Mm-hmm.
Just to answer another question of the audience. I think thank you very much, Dr. Agonimi. We would like to continue with the second speaker. The second speaker is Rosario Gomez de Liano, and she will give us her tips on the management of consecutive exotropia. Rosario, please go ahead.
Good morning, good afternoon, and thank you very much for this very kind invitation, both to IPOS and EAPOS. I have no conflict of interest to declare. While dealing When dealing with consecutive exotropia, I think we have many different types of patients and scenarios. Rarely we have children with spontaneous consecutive exotropia, as this girl that we see here, that no one could predict that over the years spontaneously could go into exo. Sometimes those evolution go very slowly over the years until they have a large deviation when they come for surgery. Usually those patients, they have sensorial factors, they have V patterns or A patterns, and they have mild limitations. A different type of strabismus of consecutive esotropia are patients who have been treated with Botox and they go into consecutive exo. Is also very rare. At ISA meeting 2004, I presented a series of 30 patients which constitute a very low rate of consecutive esotropia. Some of them were early consecutive esotropia that were children that they didn't recover from the overcorrection, and very few we had them years after. Over the years, after more than 30 years treating with Botox, of course we have some, but this is much less frequent than after surgery. Also, those are more frequent in acquired than in infantile esotropias. Usually the characteristics of those patients is that they had a huge overcorrection and that it recovered much slower than the normal rate of recovery. But when dealing with surgery with those patients, we have fresh muscles, we have mild limitations, although we have exotropia that may be different from one eye to the other under general anesthesia, and that has to be taken into account. And the third group will be the patients with consecutive esotropia after surgery, which of course is much more frequent. The ratio varies upon the studies, which depend finally on the number of follow-ups and loss of patients. I had my personal series of 60 patients that we had some of them that were early cases and others that appear over the years, sometimes even 25 years after. The average age was 2.6, but the time until surgery passes a long time because often they have small deviations that they don't want to go back to the surgery. Most of the cases, they have limitation of a deduction, and being that a retrospective study, it was only the 65, but in my experience, most of those cases have some type of limitation of a deduction. The risk factors from all the types of consecutive esotropia are well studied. There are factors of the patient. And in the last year, we are speaking more and more about the laxity, as has been mentioned before, and some treatments, how they can act on the tendons, making some more stretch scars. There are also factors related with the type of strabismus that in general, they are related with poor binocular function or suppression, greater suppression of one eye, sometimes when you remove the glasses with an anisotropia. Another type of risk factors are the type of surgeries that they are practiced. That very large recession, excessive resection will lead to more consecutive exotropia. Of course, miscalculation can be a factor. And finally, perioperative, postoperative factors that will lead finally to this limitation of a deduction, as for instance, what I said, a messy surgery with a lot of hemorrhage, orbital fracture, incarceration, and other factors that also may deal to muscle slippage, loss, pulling to new scars, and all type of new malinsertions. The third factor is, as a tip, will be the preoperative evaluation. Of course, we are going to do a very full and well motility examination, but certain aspects are more important in that case. First, we ask always the type of strabismus and previous surgeries that, of course, we do not have them always, and sometimes even we don't have to believe them because they don't match. The patient feels awful when we don't have it, but often we have many details that we can know that what has been on. Here you can see the middle rectus insertion and a gap that you see that here you have a recession. And sometimes you have very bad insertions that allow you to see that you are going to have a very bad feel. Only my concern is when I miss it that it was a transposition or a Faden surgery because my abort and my approach to the case may be different. Also for me is important, not only the surgery has been done, but how many times this muscle has been approached. Then the third question is, what do you think is the cause of the consecutive esotropia? Some things you can know it before with the examination, others you are going to have all over with the surgery with your intraoperative adjustment. And also, is the conjunctiva a part of the restriction? Then we evaluate the verticals. Sometimes huge exotropias with small verticals, once they are aligned, they don't need surgery. So it's important to know if you need to include them in your preoperative examination and in your protocol of the surgery. Consider imaging. We don't need to image all the patients, but sometimes it can be of certain value in certain cases, but new pathologies that appear. And I will suggest to read this beautiful article from André Roth about the position of the globe under the MRI. And sometimes even an OCT can let you to help even preoperatively or intraoperatively to find the muscle within the surgery. Then your case has to be examined by steps. Once you do the first muscle, you will reevaluate what it will be, and you will do an examination once you are finished in order not to leave the eye very restricted. We will evaluate also the binocular potential and also the risk of a postoperative diplopia, which is not very frequent, but it has to be examined. And finally, a very good tip I receive examine the difficulty of your surgery. If you have a very bad scar, maybe inside is even worse, and ask for help if you need it. Going to treatment, we have 3-4 aspects. If you have a slippage, it has been discussed. Go as soon as possible. And I always say, I prefer to go on day 1 or 2, because after day 3 or 4, you will have more inflammation. And sometimes if you have it 1 week after surgery, you can even wait a little bit until it's a little bit more calmed down. You can reduce your hyperopia, which is never suggested because we will have a long-term consecutive esotropia, but sometimes patients don't want surgery, and to reduce the accommodative factor will help you a little bit. We can treat them in the early postoperative period with botulinum toxin injection. Small deviations can be cured and can be helped with botulinum toxin injection, and consider sometimes even to add bupivacaine on the medial rectus. And of course, if anything of those work, program for your next surgery. About the tips for the surgery itself, I always say each patient is different and each patient has different needs. The first question you have to do is, which is really the cause? Is it a limitation from the medial, from the lateral? Or it is a matter of tonus change or sensorial or a myopia therapy over the years? Then the second question that I got it from Honoré is, go first to the problem and then reconsider to the protocol. If you think the problem is the medial rectus, that's the first muscle you have to approach. The third question is about what Jan said today. Learn where is the meat. Learn a lot about muscle attachment. What is a lost muscle? When that is one of my pictures. When you go there, you see, you thought you had the muscle, but of course it's not the muscle. The muscle is really here behind. But look a lot of pictures. There are plenty on the slides. And I took all those which are really beautiful from Irene's Ludwig book. But of course, there's a beautiful pictures. Here you see there's a tendon. Here you begin to see your mid. Here you begin to see your mid. And here you have a little slipped scar that you have it here. But we know that often that are not our fields, and our fields sometimes are too bloody and not so beautiful. And Jonathan Holmes with John and Leske did a beautiful paper in which the disagreement was in 40% of the patients. Then how to dose the medial rectus advancing, where to place, that's the clue. And we have tables that say that between 2.4 to 4 of advancement. But that is like with the thyroids, that doesn't work always, because it will depend where you have the muscle. If you find the muscles at 70 millimeters recess, that will be a really extraordinary fibrotic muscle. Then when you advance, you're going to have a huge restriction of abduction, and you will have a consecutive exo that the patient wouldn't like. You have to look the characteristics of the muscles. Where do you leave your muscle? Where is going to place it? I always said that if you have it very behind, you cannot leave it in the recession. Usually you have to do it 1 or 2 millimeters behind. Resect the scar tissue because you have to attach the muscle to the sclera, and consider absorbable sutures that, although they can create extrusion and can be a problem, but sometimes if you have a really factor associated to stretched scar, maybe the absorbable suture can prevent from new stretched scar. And then often we need to recess the antagonist, the lateral rectus recession, because it's tight, especially when you have large consecutive exotropia, long-standing. And I suggest either you do it with topical anesthesia or you place an adjustable, because it will help you a lot to the adjustment of the patient. Manage with care the conjunctiva. You have too much resected. If you have restricted recesses, if you have it very ugly, transpose another part of the conjunctiva, but leave a nice visual field. The next tip will be when to avoid topical anesthesia. In our institution, the traditional surgery are done with topical, but if you have a lost muscle, maybe the best chance you have to recover the muscle is without a topical. So consider if you're going to have pros or against with a topical, and everyone with their experience would select the best for the patient. Plan an overcorrection. We always said that we need an exodrift, especially in long-standing and very large recessions, overcorrections. And usually the numbers tell us that you need between 9, 10, and 14 diopters overcorrection. But not every patient is the same. I always say, look to the face and the couple angle. And if they are elderly, I learned from John Lee a very nice thing that, you know, if you have an elderly patient with a huge exotropia, if you overcorrected, she will be miserable because she was used to see her exo. And if she has a consecutive exotropia with diplopia, she will feel very bad. But as far as you overcorrect a huge amount of her exotropia, he will be delighted and she will see her ortho. And finally, prevent the patient that multiple surgeries may leave some restrictions. If you didn't improve your restriction, maybe you have a flap tear that you didn't retrieve, and prevent them about transitory diplopia. And with that, I would like to give you greetings from Madrid and to remember our next meeting from the International Strabismological Association. Thank you very much. And
thank you, Rosario, for this nice presentation. And my first question is, how much do you find that the consecutive exotropia, especially after infantile esotropia or acquired form, more? Which is more?
I have it much more often in infantile esotropia, but our population is a mixed population. We had lots of botulinum toxin injection in our children. So I think we are biasing those numbers. We don't have so many children with very early surgeries because most of the children below age of 1 either received Botox or they are not operated. So I think the consecutive exotropia ratio in our country is a little bit lower in this type of patient.
Yes.
And second, if we do first Botox and then we do surgery, the amount of recession is smaller. So we don't have so many children with bimedial recession of 6.5, 7 millimeters.
I know that you have a very big experience in Botox injection, and my question is, when you are doing Botox and then doing surgery, do you find any pathological changes at the muscle or around the tissue or the yolk or the tenon capsule from the injection or?
No, I just see that sometimes those patients are exo under general anesthesia, and that may be for some a suggestion either to do Faden or Faden recession or to go on to a smaller recession. The only thing is when I find them quite exo, I never do large recessions. I reduce a little bit the amount.
And the other issue, when you are doing replacement of the medial recti, I appreciate that you are removing the scar tissue because it is very important that this gives an abnormal elongation of the tendon. So when we do an advancement, it's not a real advancement. Do you think that it is sufficient only to reattach the medial recti in treatment of consecutive exotropia, especially if you have an exudation of about 15 prism diopter? Is it enough, or you have to add a lateral rectus recession, or what do you think about this?
I think that's one of the most nicest things from strabismology, that is something that you see that your experience gives you something different that doesn't say the books. And sometimes it's difficult to explain to the residents why yes and why not. I think the traction tests are crucial. If you have a very tight eye and you do spring balance tests after the surgery, and those tests will suggest to do it or not. So if I have a huge consecutive esotropia, most cases have tight lateral rectus and you need to do it. If you have smaller, as you said, 15, sometimes medial rectus advancement is enough.
Thank you.
Sorry. Rosario, there were a few questions coming from the audience. Does severe amblyopia change your surgical plan? Short answer.
Usually I try to go to the, if it is a huge amblyopia, to that eye. But if you have restricted eye, you have to convince the patient what is the best for the surgery.
Okay. Another question is, would adjustable sutures reduce the incidence of a redo surgery?
Well, I began in the 85 with adjustables, and many years I was working with adjustables. Then we set by the 90s to the topical. So if I wouldn't have adjustable, I like to give the option of adjustable. Maybe you can have many cases in which you don't need it, but at least I sleep better and I know that some hours after I want to change.
Yeah, talking about sleeping better, there was a question, what are the indications to advance a recessed muscle anterior of the original insertion? I never done that, but...
I don't know, to advance it, yes, in Portugal they
do advance this, but then attach it in between the insertion and the limbus.
Yes. Well, I haven't done it, but in Portugal we have a colleague that has a huge experience, and I plan to do when I have a very slack muscle, but often in consecutive exotropia, the medial rectus is so tight that I can not even leave it on the insertion. Most of my cases are 1 millimeter behind.
Okay. Last question, what role does patching play in consecutive exotropia? So you have a consecutive exotropia and then you do alternate patching. Do you think it has a role?
I took it this morning, this sentence off my slides, because I think it has a role for the very early period. It augments fusion, and certain cases, I think it does more in consecutive ESO than in, but it has a role.
Thank you. Adel, would you like to introduce the next speaker, please?
Yes, the next talk by Dr. Lubna Khazbak, management of residual horizontal deviation. It's a big issue, so it needs a lot of time to discuss this. Go ahead, Dr. Lubna.
Okay, angle of deviation, the higher the angle of deviation, residual esotropia. The incidence of undercorrection and the recurrence of esotropia varied from 20% to 40%. There are many prognostic factors for the success of esotropia surgery, including age at surgery. The older the age, the better the prognosis. Preoperative angle of deviation, the higher the angle of deviation, the more incidence of recurrence. High hyperopic errors and changes in it and in the esotropia, it may regress during the early year of life, so may result in reoperation. Lateral rectus underaction and the presence of nystagmus are also prognostic factors. Residual esotropia, how did we get to? If we know how did we get to, we can avoid it. There are many factors, preoperative, operative, and postoperative factors. Preoperative factors include missing refractive errors, angle measurement with the glasses, sensory evaluation, limitation of ductions, nystagmus blockage, near-far dissociation, and alphabetical patterns. Missing refractive errors should be avoided by doing cycloplegia with atropine. Angle measurement with the glasses, as you know, the high plus lens act as two prisms base to base, and the minus lenses as two prisms apex to apex. When we measure the deviation through the plus lens, we actually measure less than the real angle of deviation due to the prismatic effect. So minus lenses measure more and plus lenses measure less. The true deviation at distance in front of the glasses is changed by a percentage of approximately 2.5 times the bilateral spectacle lens power. Here are the tables which you can use to correct for the prismatic effect of the glasses while measuring through minus or plus limit. Sensory evaluation is very important. Knowing the fusional range of the patient, depth and size of the suppression scotoma, the presence of amblyopia and eccentric fixation are important factors in recurrence of the deviation. To detect limitation of ductions, measurement of the angle should be done in primary, secondary, and tertiary gaze positions. Diagnosing and properly managing nystagmus blockage, this avoids undercorrection. Also detection of near-far dissociation and its management by whether bifocals, Faden operation or slanted recession also should be done to avoid undercorrections. Also alphabetical patterns should be diagnosed and well managed. There are many studies that found that the younger the age and the presence of fundus torsion at the first surgery are risk factors for recurrent esotropia. Operative factors, the force reduction test should be done in 3 stepwise. Before opening the conjunctiva, after opening the conjunctiva, and after disinsertion of the muscle. And if there is any restrictions, they should be released. Abnormal insertion of the medial rectus, if you find it, you should measure from the limbus and how far you place your sutures away from the insertion. For example, if you put your sutures open 5 millimeters away from the insertion, you should add this open 5 millimeters to the number of recessions to avoid residual esotropia. Also, if you have any deformity, V-shaped deformity of the insertional stem, don't measure from the apex of the V, but measure from the most posterior part of the insertion to avoid undercorrection. Correction or
Post-operative factors, proper correction of refractive errors bifocal if needed, and abstain from excess use of smartphones in the immediate post-operative
correction or recurrence of deviation. As regards the management of recurrent esotropia, it is whether non-surgical or surgical, non-surgical, optical, glasses or bifocals, or buttocks and bupivacaine may be used, or surgical. For the surgical treatment, you should have records of the previous surgery, number of previous surgeries and its timing. If you don't have such records, search for the site of the conjunctival scar and old photographs to have a clue of what has been. There are many surgical options. Medial rectus recession is done up to 13.5 millimeters from the limbus for those who underwent bimedial rectus recession 5 millimeters or less with no limited eduction. Also, lateral rectus resection, whether unilateral or bilateral, is an option, but also not in cases of medial rectus restriction. And operating on freshly untouched muscle gives more stable and predictable results. Marginal myotomies can be done on the medial rectus, but this has the disadvantage of much more bleeding and consequently much more adhesions and fibrosis, and the results are unpredictable, but you can increase the predictability by combining it with lateral rectus resection. Faden operation or pulley fixation can be added to the recessed medial recti in cases of high ACA ratio and nystagmus blockage if this wasn't done before. Also, Faden plus central tenotomy can be an option. Be also used. This is a summary of the surgical treatment of residual and recurrent esotropia with its success rates. Here is some surgical tips in reoperation. You should do force reduction test, as I said before, in 3 stepwise. And here we start. Here is the scar tissue of the previous operation, and we start in a fresh conjunctiva, a snip in a fresh conjunctiva, and then advance our dissection toward the area of adhesions to avoid any buttonholing of the conjunctiva. Of course, operating under the microscope gives you better visibility, and limbal incision also gives you better surgical field. When you place your hook, if you place your hook much more anterior, you are actually hooking a pseudotendon, not the real muscle. You know that the medial rectus is recessed. So you should place your hook much more posterior to get the muscle where it is in its recessed place. And then I always keep the hook in its place under the muscle to know where the muscle is. It is usually involved in the scar tissue, and then start to dissect the conjunctiva until I reach the muscle. Always keep your scissors on the under surface of the tenon away from the muscle and the sclera to avoid damaging of the muscle. Here is the recessed muscle, and then I put another hook and test for the elasticity and stretchability of the muscle. And the 2 hooks keep the muscle away from the sclera. You are working in a very posterior place in an awkward situation, so this avoids the needle from damaging the sclera or perforation of the sclera. After this insertion of the muscle, you should test again for any restriction, and always take your measurement from the limbus, not from the insertion site. This is a case of recurrent esotropia with previous bimedial recessions, but the right medial rectus was found very tight, so re-recession of the medial rectus and relieving any restriction corrects the situation. Residual exotropia. The incidence of undercorrection and recurrent exotropia varied from 22 up to 60%. There are many prognostic factors as age, preoperative deviation, refractive errors, and lateral rectus. Increasing patient age at surgery was associated with lower recurrence rates. Preoperative deviation and higher myopic refractive errors were also prognostic factors. Lateral incompetence is very important as a risk factor for requiring reoperations. Also, early postoperative overcorrection minimized the tendency toward the recurrence of exotropia. However, in some studies, they concluded that the initial overcorrection were not predictable factor. Also, age at onset, age at surgery, preoperative deviation, oblique muscle dysfunction, DVD, and postoperative alignment were not found to have statistically significant effects. So the preoperative evaluation, angle measurement through the minus lenses with the correction for any error, lateral incompetence should be searched for, and any fundus torsion and alphabetical pattern. This is a case of recurrence exotropia, small angle, but there was a missed V pattern in the first surgery and was not addressed. Management is through glasses, correction of any minus error of refraction, or we have many surgical options for the treatment of recurrent or residual esotropia with its success rate as shown in the table. Recession. What to choose? In cases of previous large bilateral lateral rectus recession and small to moderate angle, you can do unilateral medial rectus resection. This is a case of recurrent exotropia, small angle with limitation of abduction. So re-recession of the lateral rectus is not an option, as it is going to exaggerate the limitation of abduction. And the solution was to do a single medial rectus resection of the in the right eye to correct the situation. In recurrent cases of up to 25 prism diopters, you can do either bilateral medial rectus resection or unilateral medial rectus resection. Doing the whole surgery on one muscle, one medial rectus muscle, this has a lower rate of overcorrection, less anesthetic time, less discomfort, and limiting the risk of complications to one eye, and leaving one single medial rectus untouched for any further surgery if needed. If you have a case with unilateral recess resect or unilateral lateral rectus recession, you can do contralateral lateral rectus recession to correct moderate angles, approximately 20 to 25 prism diopters. For cases of moderate angle up to 33 prism diopters, you can do bilateral lateral rectus recession up to 17 millimeters from the limbus. This is effective, but it may lack predictability, and it is not done in cases of any limitation of abduction. The use of adjustable sutures in residual and recurrent strabismus, whether esotropia or exotropia, of course, increases the success rate of reoperation from about 48% in the conventional method up to 65 and 72% in the adjustable group. Different surgical approaches have been recommended for correcting residual or recurrent strabismus, but there is no standard protocol for the design of operation and the evaluation of outcome. The choice of the surgical procedure depends on many factors, on the type of previous operation, on the surgical dosages, on the angle of deviation, on the presence of limitation of ocular motility, or the presence of any tight muscles and any restrictions, and also it depends on the surgeon's preference and experience. Thank you very much for your attention.
Thank you, Lubna. This was an impressive, actually two talks, one about esotropia and the other about exotropia. One of the questions which came from the audience, when do you consider marginal myotomies in residual deviations?
If the medial rectus is recessed enough and I want to weaken it more, I may consider double marginal myotomies, but if the muscle is bulky enough to do such an operation to avoid any slipped or lost muscle. It's extremely rare to do that, but if I can't re-recess the medial rectus because it is already placed posterior, I can add it.
Okay. Any other panelists who would have a question for Lubna?
I have a question for the panelists because I have an experience with when we are associating a second session of residual esotropia with inferior oblique overaction. Do you have an experience that inferior oblique recession may correct small angle esotropia? Do you have an experience about this? Because I presented a paper about this several years ago in ISA, and it was obvious that within 15 prism diopters can be corrected by just inferior oblique recession. And if we have a much more angle, we can do a marginal myotomies in association with inferior oblique recession. Do you have any experience about this or any idea about the factor of inferior oblique recession for small angle esotropia?
I don't think so. I don't have experience in that, but sometimes the patient puts his head in a down position or up position to compensate for the pattern. When you do oblique muscle surgery, improve the whole situation, but I don't think it directly affects the degree of esotropia.
And as regard to recurrent exotropia, do you try exercising prisms for small angle residual exotropia?
Residual exotropia?
Yes, exercising prism, without.
Without no, I don't try it. I usually do such orthoptic treatment preoperatively for adult cases or teenagers who have intermittent exotropia to improve their conversions, but post-operatively, I don't do that.
Yes, okay. Any question? More questions? So Dr. De Faber, you can proceed.
Yes, thank you very much, Dr. Lobna Kashbak. And then we go all the way to Japan, to Miho Sato. Hello, Miho Sato. Unmute yourself and share your screen. And you will be talking about reoperation for superior oblique palsy. Miho, go ahead.
Hello everyone, my name is. I have no financial interest to declare. Superior oblique palsy is a common cause of.
Did you hear me?
We heard you for a couple of seconds and then it muted. So maybe if the sound doesn't work, then you simply go through your slides and do it live, Miho.
Okay, thank you.
Vertical deviation in children and adults. There are many surgical procedures for superior oblique palsy, but also there are many reoperations. Why reoperations are needed? Wrong diagnosis may have been given. Wrong muscle may have been operated. Surgical technique may have been poor, and surgical dosage may have been inappropriate. Then over or undercorrections happened. Congenital superior oblique palsy is often associated with superior oblique muscle and tendon anomalies, and they show large vertical deviation. Therefore, many of them require two muscle surgeries. It can be a staging surgery or simultaneous surgery. If we perform staging, reoperation is for undercorrection. And if we operate simultaneous surgery, reoperation may be for overcorrection. Is it true? Here is the number of muscles operated on congenital superior oblique palsy patients. We divided the patients by the MRI findings and compared between normal superior oblique and hypoplastic superior oblique groups. When the superior oblique muscle was normal in size, average number of operated muscles was 1.23. But when the muscle was hypoplastic, the number increased to 1.90, almost 2 muscles. Therefore, when we operate 2 muscles simultaneously on hypoplastic superior oblique cases, we may be able to reduce reoperation. How to recognize superior oblique hypoplasia? Superior oblique muscle hypoplasia is strongly related to superior oblique tendon laxity. Therefore, superior oblique tendon is the key for surgical success. Here is our surgical strategy for congenital superior oblique palsy. We perform superior oblique tendon traction test under general anesthesia. When tendon is normal, we perform inferior oblique myectomy alone. If the tendon is lax, we perform inferior oblique myectomy and superior oblique tuck. If tendon was absent, we perform superior rectus recess or contralateral inferior rectus muscle recession. This is superior oblique tendon traction test. Superior oblique tendon of the left eye was very lax and no feeling of the tendon. And the superior tendon of the right eye was normal tightness. At the end of inferior oblique myectomy and superior oblique tendon tuck, superior oblique tendon traction test is repeated until the tightness matches to the right eye. This is the preoperative vertical deviation and postoperative vertical deviation after inferior oblique myectomy alone and inferior oblique myectomy with superior oblique tuck. Preoperatively, the angle was significantly large in two muscle surgery group, but postoperatively, the deviation became small and not significantly different between two groups. When superior oblique tuck was performed, Brown syndrome is observed immediate postoperative period. But, as this case, Brown syndrome disappeared afterward. We started two muscle simultaneous surgery from 2002. Then the surgical success became much better than before. We still had undercorrection in two muscle groups, but we did not experience Brown syndrome. Now, let's think about the steps for reoperation. Sometimes the previous surgery is unknown. In that case, we look conjunctival scar very carefully under slit-lamp microscopes. Sometimes we ask patient to show all the photos, or we ask the previous surgeon about the surgery. When the first surgery was done on inferior oblique, there are overcorrection and undercorrection. The options for the second surgery of overcorrection were contralateral inferior oblique weakening or reverse inferior oblique for anti-elevation syndrome. For undercorrection, reverse inferior oblique, tuck superior oblique, and contralateral inferior rectus muscle recession are the options. We have to consider revision of a previously operated inferior oblique on both overcorrection and undercorrection. When superior oblique was operated, there are also overcorrection and undercorrection. In case of overcorrection, we have to revise the superior oblique. In case of undercorrection, we can operate inferior oblique, if not operated before, contralateral inferior rectus muscle recession or superior rectus muscle recession. Also, we may revise the superior oblique tuck. Division of superior muscle may be necessary for both overcorrection and undercorrection. Let me show some operative movies. This is the case previously myectomized by myself. Careful observation revealed inferior oblique muscle was completely dissected. Then I performed the superior oblique tuck. So look carefully inside the tenons. And here is a vortex vein, and there are no remnant inferior oblique muscle. This is a case operated by someone else. Scar was observed on conjunctiva. The scar was opened and carefully look inside. Sometimes tendon capsule is very tight and difficult to open. But in this case, here you can see inferior oblique muscle almost intact. Then myectomy was performed. This is a patient after superior oblique tendon tuck. It was effective for a while, but 2 months after the surgery, hypertropia came back. Then, traction test showed very lax superior oblique tendon, and it suggests tendon tuck was loosened. Then superior rectus muscle was detached from the sclera, and superior oblique was revised. Here you can see the suture was pulled up and not fixed on the sclera. I performed superior oblique advancement on this patient. This is the worst fat adhesion syndrome I've ever experienced. This patient underwent inferior oblique muscle recession 30 years ago, and diplopia progressed gradually. Upon surgery, severe adhesion was observed around inferior rectus and inferior oblique. Adhesion was released and inferior rectus muscle was recessed, but limitation of upgaze remained. Take-home messages. Intraoperative traction test is important and helpful. Revision of previous surgery is often necessary. Plan and perform first surgery very carefully. Thank you for your attention.
Thank you, Dr. Yes.
Go ahead.
Okay, go ahead.
Adel.
Yeah. Thank you, Dr. Minho, for this presentation. The question is it is usually asked about the difference between myectomy of inferior oblique myectomy and recession as regarded inferior oblique recession is a guarded procedure, and if you are going to reoperate, it's much easier than to find the muscle after myectomy. What's your opinion about these two techniques?
Well, yeah, there are several options for inferior oblique myectomy or advancement or recessions, and I do both. And also, if the patient has a DVD, I prefer to do inferior oblique anti-transposition. But otherwise, I prefer to do myectomy. And as I showed the last case, the trouble may be more on on recession rather than myectomy, I feel. So I prefer to do myectomy.
Yes. Any questions?
Yes, there was a question for Dr. Miyosato. Does Harada-Ito cause a Brown syndrome?
Harada-Ito, well, I don't usually do Harada-Ito so many cases. I've never had the Brown syndrome. Immediately after the surgery, many patients had too much intorsion and not like Brown syndrome.
Okay. Yeah, that's my experience as well. So that answers the question of Dr. Shetty. And then a question: to work on a single or two muscles in superior oblique palsy is only based on traction test or also by the angle of deviation?
Yeah, I also think about the deviation. Usually, though the patient had larger than 15 degrees, 15 prism diopters or larger, but sometimes the patient had a very small angle of deviation, but a very lax tendon. In that case, it's really, really difficult to decide. In that case, I prefer to wait for superior oblique.
Another question is, Dr. Miyosato, what do you think about inferior oblique weakening and superior oblique full tendon advancement in a patient with a NEP class 2 or 3 superior oblique palsy and moderate and high degree of hyperdeviation?
Let me think. Well, class 2, you mean no inferior oblique overaction, is that right?
Yep.
Okay. In that case, still I prefer to do inferior oblique myectomy. I have some patient performed only superior oblique tuck. Usually it doesn't work enough. So they may need to inferior oblique weakening procedure in later.
Okay, thank you, Miho. Those were the questions we would like to address. And Adel, could you
Yes.
please introduce the next speaker?
Yeah, because we have to hurry up because we have a limited time now. Dr. Ahmad Awadin will present reoperations for paralytic strabismus. How early is too early?
Hello, everyone. In paralytic strabismus, adjustment of the surgical dose is difficult. The two main variables that the surgeon can control are the technique of the muscle transposition and the amount of weakening of the antagonist muscle. The accuracy can be improved by using adjustable sutures or by staging the procedure. Nevertheless, adjustable sutures have many limitations. In addition, there is always some post-operative drift towards the original alignment, which should be taken in consideration. The amount of drift is more with partial tendon than with full tendon transposition. This patient, for example, had a right 6 nerve palsy. She had an excellent alignment on the first day after surgery, but you can notice a small esotropic drift 1 month after. On the other hand, this patient with a right 6 nerve palsy had a small overcorrection on the first day after surgery, but 1 month after, this overcorrection disappeared. Still, the response to surgery is influenced by many variables, such as the degree of paresis of the involved muscle, the degree of tightness of the antagonist muscle, the secondary changes in the orbital tissues, and the limited number of functioning muscles available to work with. So nevertheless, how hard you try, you will always encounter some undercorrection. So when reoperating for undercorrection, one has to consider several variables. The first of which is to do a force reduction and look for any residual tightness of the antagonist muscle, which should be relieved if present. This patient, for example, had a right 6 nerve palsy, had only a right Janssen procedure with no medial rectus recession, but because the medial rectus was tight, he had some undercorrection after surgery. And after performing a right medial rectus recession, the alignment could be improved. The second variables that should be considered are the ductions and the versions in side and vertical gazes. So if the antagonist muscle is not tight, the management will depend on the residual angle in the primary position and whether the eye can cross the midline or not. If the residual angle is small and the eye can cross the midline, one can consider doing a contralateral eye muscle surgery by weakening of the yoke muscle. This will help to correct a small misalignment. It will increase the innervational tone to the paralytic muscle and will increase the binocular field of vision. The standard way is to do a posterior scleral fixation with or without muscle recession. This patient had a residual undercorrection following a transposition and left medial rectus recession, but you can see that the eye can now barely cross the midline. After performing a right medial rectus faden suture, the alignment could be improved. The alternative for faden is to do a combined recession resection, or what is known as the Scott procedure, in which a large recession is performed to reduce the torque of the muscle, and this is combined with a small resection to keep the muscle tone. This child had the right 6 nerve palsy. At first, he had the right medial rectus recession and a transposition procedure with residual misalignment, but you can notice now that the eye can cross the midline. So in this patient, after performing a combined recession resection on the yoke muscle, that is the left medial rectus, both the alignment and the abduction can be improved. Now, if the angle is large and the eye cannot reach the midline, unfortunately, you have to consider further increasing the tone on the paralytic gaze. This usually implies adding more resection, more or a different type of transposition, and correcting any misdiagnosed pathology. Remember that you should not always give up on resection, even in paralytic strabismus. Sometimes it works if there is some tone or function of the medial rectus. This patient, for example, had a right third nerve palsy and had a prior right lateral rectus recession and a right medial rectus resection. But you can notice that he still has some function of the right medial rectus. After performing a right lateral rectus orbital wall fixation together with some medial rectus supramaximal resection, the alignment and the adduction can be improved. In many cases, when you have no function of the paralytic muscle, you have to consider a different type of transposition. This is another patient with a left third nerve palsy who had a prior lateral rectus recession and medial rectus resection. Notice that he also has some hypotropia in the primary position, which made me think that we could do a left oblique and medial transposition to improve both the vertical and the horizontal misalignment. Now, this is another patient who suffered from a large injury to the medial rectus following an endoscopic sinus surgery. He presented with a large exotropia and a marked limitation of abduction. In the first surgery, I performed a full tendon vertical rectus muscle transposition with vessel sparing, but because the angle was large, you can notice that he still had a marked undercorrection. So in the second surgery, I went to do a right lateral rectus recession, which was not performed in the first surgery, but again with a very poor response. You can notice that the eye still cannot even reach the midline, so you have to further increase the tone on the paralytic gaze. So I had to go back and do a medial transposition of a split lateral rectus to improve the alignment in the primary position. One issue that you should look for is any missing pathology. This patient, for example, was misdiagnosed as a right fixed nerve palsy, and she had a previous right medial rectus recession and lateral rectus resection more than one time with no improvement. The patient was a high myope and definitely had the diagnosis of heavy eye syndrome. After performing a Yokoyama procedure, you can notice that you can improve the alignment in the primary position as well as the abduction. Another factor that should be considered during reoperations for paralytic strabismus is the anterior segment circulation. One might consider using imaging of the anterior segment circulation using angiography if possible, and should look for alternatives to minimize the risk of anterior segment ischemia. For example, for recession, one might consider doing a vessel sparing technique by isolation of the muscular arteries before muscle disinsertion. Another way is to do a muscle fenestration technique in which the central part of the muscle is removed, leaving the peripheral fibers intact together with the muscular arteries. And definitely one has always to consider the use of Botox injection instead of conventional eye muscle surgery. For transpositions, one might go more for split tendon transposition or use transpositions with no disinsertion, such as the Nishida procedure, to preserve the ciliary vessels. And for strengthening procedures, you might go more for tucking and plication rather than resection. So while undercorrection is far more common than overcorrection, overcorrection does occur. This patient, for example, presented with a left 6 nerve palsy and a -5 limitation of abduction. He had a full tendon transposition with augmentation sutures and no medial rectus muscle recession. But following surgery, he had a large overcorrection with a large exotropia. In this patient, we waited for 4 months aiming for some improvement. But after 4 months, we had to go back and to cut the augmentation sutures and do complete reversal of the transposition. But you can notice that there was low or even little improvement of the misalignment. Now, this is another patient who presented with a right 6 nerve palsy and a -4 limitation of abduction. Again, this patient had a right medial rectus recession and Jensen procedure. And on the second day after surgery, she presented with a large overcorrection and a terrible diplopia. In this patient, we did not wait as long as the first one, So we went back only 1 week after surgery. We explored the medial rectus and found that it was in place. So we had to go back and to take off the Janssen sutures and do a complete reversal of the transposition and put the transverse muscle back to the original position only 1 week after surgery. After the reversal of the transposition, the patient had an acceptable alignment, and the alignment remains stable even after 3 weeks. So this probably means that whenever you have an overcorrection after transposition, one might consider early reversal of the transposition before these changes become irreversible. Thank you.
Excellent, Ahmed. This were very illustrative examples of your patients and patients of your colleagues. So the lesson or the take-home message is: whenever you have an overcorrection, don't wait too long to put the patient back in primary position again. One of the questions, Francesco Reich-D'Almeida already put 3 questions, which you obviously already have answered, using Botox in the antagonist, and what kind of transposition would be your favorite in palsies? The ones with foster augmentation, or you keep the Nishida technique, in which you don't take off any part of the vertical muscle?
I think the Nishida procedure is gaining popularity now. It preserves the ciliary circulation. It is a very potent surgery, slightly more potent, for example, than the partial tendon transpositions that I used to perform. And I think it also increases the binocular field of vision slightly more than the usual surgeries.
Thank you. Are there any preoperative risk factors that can predict overcorrection?
Well, I cannot actually tell, but I think that most of the overcorrection would occur in patients with -4 limitation rather than those with -5 limitation for abduction. So probably in patients I should be a bit more cautious.
Yeah, I think my rule of thumb is that when the patient is able to get to the midline, do recess, resect, or Botox without transpositioning. But if it's worse, then you need some heavier ammunition in surgical terms. Adel, would you have any more questions?
Just a comment that I don't believe that resection of the weak muscle without tone could affect. So I go for antagonist resection and the transposition for the weak muscle. I think this works much more correctable for me, at least. Yeah.
Mm-hmm. Okay, I think that's no more other questions from other panelists. No more questions. Then I would like to introduce the last speaker, Saurabh Jain, Intraoperative Tricks for Reoperation. Jain, the audience and the screen is yours.
Thank you very much, Dr. Defaba, and thank you very much to the organizing committee for inviting me to speak. And I'd also like to thank all the excellent talks we've heard, the panelists for the excellent talks we've heard so far. So my talk really is going to be a amalgamation of things we already heard, because most of my work has been done for me, really. So one thing we all know when we operate on patients who need reoperation, that these patients are tricky. So it is essential to really manage their expectations and carefully consent them, because you're not going to be able to get them straight in every direction of gaze afterwards. One of the things I found very important when evaluating the patients, even before you get to the operating theater, is to find out why they come to you. What are their current symptoms? Can you have any details of the previous surgery? Which eye, which muscle? If you're very lucky, maybe in how much to what muscle? I do insist on a careful assessment of motility. In the UK, we are very lucky. We have orthoptists who do this for us. And I insist on a 9-gaze measurement for all these patients, especially if there is any evidence of incompetence, as well as a measurement of near and distance to look for near distance disparity. The palpebral aperture measurements can also give you a clue, because if you have a small palpebral aperture, you know they probably had an over resection of something you may need to tackle to give them proper cosmesis. So I'll start by telling you about this case of a 23-year-old white woman who came to us after initially having an operation for a convergent squint at 4 years of age, and she felt things were fine, but they had since returned, and this was what the orthoptic report showed, and this is what she looked like. And you can see, yes, there is a left exotropia, but slightly reduced vision. If you look to the right, you can see immediately there's a limitation of adduction on the right gaze, and the left gaze is fine. So that's a 9 gaze, and then immediately you can see the problem. There appears to be a limitation of the adduction of the left eye, and that now explains why the deviation is more for near than for distance. But then to complete your assessment, you need a measurement in lateral gaze, and again it shows very quickly that it's much more on right gaze compared to left gaze, which again makes sense, and it's all fits into a MR, a slipped medial rectus on the left side, which is what you need to tackle. Now, when you do the operation, things I found really helpful is to really look at what I find and help it guide intraoperative management, so I can change what I'm doing as I go along. And one of the things that really helps me, the force reduction test can be my best friend. And I just want to show you these things through some videos, as well as these other principles that I put on the slide. In interest of time, I'm just going to show you the videos and I'll talk about them. So the first thing is, if you're going to, this is me hooking a recessed muscle, and you can see this is a redo procedure. There's lots of Tenon's capsule. I'm having to go through the Tenon's capsule to open the muscle, and I find the muscle looks really small. It should be a lot more spread out. So always rehook and see the any more muscle fibers hanging around that you have missed, and that's exactly what's happened here. So the muscle has been split during the first procedure, and now you find there's another bit of the muscle that you would have missed if you hadn't taken into account the missing muscle fiber. Then you get then less effect of your readvancement. So always make sure that the anatomy makes sense to you. Okay. Going forward, people talk about a stretch scar already, and just to reinforce, look for the B. If you look where the muscle starts, do not just put sutures into your tendon. You will not really get the effect you want. Here's another video of me recessing, doing a readvancement of a recessed muscle. This is a very powerful procedure, and if you do it properly, you really can get very good results. I tend not to go beyond. You can see here the original insertion here. I never go beyond that. So suturing is key. You have to have 3-point insertions. So I do 2 full thickness sutures in the middle, a partial thickness, and then a full thickness lock. And similarly on the other side, I do a partial thickness, and then I do a full thickness lock. So I get at least a 3-point fixation for every muscle. And I feel that is really important if you're going to be able to attach the muscle and take all the muscle fibers along with you on the journey, and not run the risk of having some muscle fibers leave behind. I always make a fornix incision. You can see how the conjunctiva is completely tied down there because of the previous limbal incision. And then you make new tunnels. You measure where you're going to attach the muscle. I always attach it where the original insertion was, and you can then get the effect you want. If you feel that's not going to be enough, you can resect the muscle, but I never advance it more than the limbus, because I feel it gives you really ugly result, and people are very aware of it. And in today's world, people are much more image conscious than they used to be. Okay, so this is the point I was making, that you really want at least a 3. This is from Ken Wright's excellent article on his 10 commandments, and you really need at least a 3-point fixation where you have 3 full thickness sutures, so that you take the whole muscle along and you don't slip any muscle fibers. Just a point about the force reduction test. So I use it just to, you can see he has a very loose superior tendon. I don't do the guidance test. I find this gives me enough information, so I don't have to rupture the conjunctiva at 2 places. And really what you're aiming for at the end of your procedure is a nice tight tendon. So you do give them a Brown syndrome, and you have to give them a Brown syndrome if you want to get success. And what I aim for, if you draw a line between the 2 canthi, that the limbus just clears the line when you finished. But it's really important to ask the patient before you start this what they do. So if they are a pro cyclist, or they have dropped handlebars, or if they're darts player, then of course this Brown is going to impact on their life. As Mio said, not forever, but at least for the first few weeks or months. Adjustable sutures really help. So you can either use a noose technique when you slide the noose up and down, or a bow tie technique, which is what I use, which again, I find very helpful. So this is a muscle that is being recessed. And once you finish your recession, I do a hang back, and I do a 3 throw on which I tie a bow tie. And I find, especially in redos, this is really important because this gives you then another layer of security. So when the patient wakes up, if the effect is not quite what you want, you can do something about it. So I try not to open the conjunctiva. So what I do is once I finish, I put both the sutures through the little fornix incision. I suture them onto the lid. When the patient wakes up, you measure, and it's not what you want, you pull the short end, the bow tie is released, and then you can tighten it and then eventually cut them off, and it actually works very well. You don't even have to undo the conjunctival suture normally. So that works very well for me, and I find in redo procedures, using an adjustable suture is really helpful. I adjust between 6 and 24 hours following the procedure. I usually let the patient wake up completely because you really want the sensory mechanisms to kick in. Until lots and lots of topical anesthetic, I don't usually use a speculum. So patients don't mind being adjusted in this way. I just use 2 tying forceps and Westcott scissors, and I gently hold the lids apart using fingers. You need a good assistant, or at least, at the very least, a good light source to be able to do this. So just to summarize this rapid presentation, what I find useful in redo procedures is to manage patient expectations. What I say to them is your world is 9 squares, and what I'm going to try and do is get you straight in this square and this square, because that's for 90% of your life. If you get the rest of them straight, that's great. I always insist on 9-gaze measurements preoperatively. I find meticulous dissection is absolutely essential to get the result you want, and you have to have 3-point suturing. You have to be able to differentiate muscle from scar tissue, as Rosario was saying. Get your field free of blood if you absolutely have to, but you need to be able to do that. Use your force reduction test well, and use your intraoperative findings to guide what you should do next. I use a fornix incision because it keeps me away from the scarring of the limbal incision, and I find adjustable sutures are a very useful adjunct. Thank you very much for your attention and for your time.
Thank you, Dr. Jain. I ask you about your experience when you are reoperating and find a vertical displacement of the horizontal muscle. Does it change your decision, or you are taking as another measures, or just re-recess in the proper direction?
So again, as I said in my talk, you treat every case like a new case. So if when you're planning the case, there's no vertical displacement, then I would not touch the muscles, or I would not displace them vertically again. If there's an A or V pattern and you really want to get rid of it, I think that's fine. Then it's absolutely worthwhile, moving the muscles, but I wouldn't move them otherwise.
There was a question from the audience. Amr Mohammed asked, which is better for a reoperation, fornix or limbal incision?
So again, what is better is what you use for, what you used to. And I think you'll find that people are almost religious about their own incision. It doesn't matter. I find the fornix incision for me works much better because I can stay away from the scarring that usually happens following a limbal incision, especially in older patients, because conjunctiva is so friable. It just completely, it's like wet tissue paper. So that's why it works for me. But really the incision that matters is the one you used to.
Mm-hmm.
Do you use aggressively bipolar cauterization, or you keep tissue safe without any cautery, especially for recurrent cases?
Yeah, so I was trained by Irene Gottlob, who was completely against cautery of any kind at any time. So that's how I was trained. Now, because I can do what I want, I do a little bit of cautery, but be careful. Every cautery you do is going to cause some scarring. So it's not a victim. It might make your life a little bit easier at that time. So if we put in some drops of adrenaline before you start, I think that helps. But yeah, and as I tell the residents, all bleeding stops eventually. Just some patience and it stops.
I agree with you totally.
Another question from Nemir Bagat. Do you consider resected stretch scars in your surgical dose?
Well, if I see a stretch scar, I get rid of the stretch scar, and then I deal with what's left. And this is why I find adjustable sutures so helpful, because sometimes it's very difficult. You see a scar, you resected it, you put the muscle back for it, and you just don't know what you're going to get. And I think adjustable sutures on a recessed muscle just give you that extra layer of security that you can modify things a little bit afterwards.
Okay. Any other questions of the panelists? If not, then I would like to give Jason Yam the podium, because he would like to invite people for the next webinar. Jason.
Thank you, Dr. Divabra. I hope our audience all enjoyed this wonderful webinar. Our first webinar with joint webinar, IPOSC joint webinar with the EAPOS. And in June, we will have another webinar, this time with our Lebanon colleagues, the Lebanese American University. In June 12th, Saturday, we will have Dr. Mohammed Jafar, Dr. Jamal Blake, and Dr. Ahmad Sadaka to moderate for us. And we will have star faculties again with Dr. Jane Edmond, Dr. Gina Hadri, Dr. Sain Donald Hu, and Dr. Ghana and Dr. Eldari to speak for us. So please stay connected with us and receive our newsletter and join our webinar. Thank you very much.
Thank you, Jason, for this tip for next month. I will certainly participate. I enjoyed this webinar, which we had today in conjunction with the Egyptian Society for Pediatric Ophthalmology and Strabismus in connection with IPOSC and supported by the American Academy of Ophthalmology. I would like to thank all speakers and all panelists and the people who participated. And what I expect is that this webinar was recorded. It will be put on YouTube, so you can enjoy it once more, or take notes from some presentations which might went a little bit too quick. Adel, would you like to close the session, since you're the Egyptian moderator?
Yes, I'm very happy for this cooperation, and I wish that we have more and more webinars. And I'm looking forward for a live meeting, actually, after the Corona episode, to meet again and to have a good time together as usual.
Yeah, actually, Adel and I, we met 26 years ago when I gave my first lecture in Cairo, Gizeh, and we became lifelong friends. And now you see, during COVID pandemic, we have to meet through Zoom. But anyway, let's hope that we can hug each other in the coming year when everybody is vaccinated.
I hope so. I hope so. Bye bye.
Okay. Thank you very much.
Thank you all. Thank you all.
I would like to close the meeting. Thank you very much to all of you.
Thank you.